I would like to introduce the intra-articular high tibial osteotomy, which is called the Tibial Condylar Valgus osteotomy in this talk. Essentially, I'll reiterate again, this hopefully is going to be a session where one just opens one's mind to what may be possible. So this is a talk put together as an analysis of the first 24 odd cases that were done by my ex-fellow and associate surgeon and presented recently at the Lisbon World Congress. So we all know about the different high tibial osteotomies for medial compartment arthritis. These are all examples of the extra-articular high tibial osteotomies, a closing wedge, a medial opening wedge, a fixator-assisted plating, and also the precise nail, which is the optiline for accurate gradual correction, internal fixation. Wonderful. These are all for extra-articular deformity correction. Even if you do perform the double osteotomy, that's a lower femur, that's still 2 extra-articular deformity corrections. The question arises is, with our knowledge of the mechanical axis planning, mechanical axis deviation, which came to us more than 20 years ago, where is the deformity? So we really should be looking at. So in this patient, obviously the deformity is extra-articular and she will benefit for a mild deformity with a medial opening wedge high tibial osteotomy. This is the lady with a larger osteotomy, but needs a larger osteotomy, but it is an extra-articular deformity as well. Where is this deformity? If you look at the full-length X-ray, this is a large joint line convergence angle, and the 2 tibial condyles don't seem to be perfectly collinear. There is a very obvious large metaphyseal extra-articular deformity. So when we answer this question, then we are ready to perform bespoke correction or a la carte correction for these problems. So I'd like to introduce to you the tibial condylar valgus osteotomy in its 2 avatars. The one on the left is the pure intra-articular osteotomy fixed with an ordinary locking plate, and here is a double intra-articular plus extra-articular osteotomy, which currently we can only use external fixations to fix and correct. This was written up by Professor Tsukasa Teramoto from Koriyama City in the Journal of Limb Lengthening and Reconstruction. I'll take a brief moment. Gemma has a few copies of the journal back there with her that I have brought, the latest issue of the journal. And Professor Teramoto went to great length to write about the controversy of high tibial osteotomy. Why do we need to perform intra-articular corrections in certain cases? And why purely extra-articular corrections are not enough? So it's well worth a read. This is available, the Journal of Limb Lengthening and Reconstruction is available for you to read for free in the HTML format on the web. The address is jlimblengthrecon.org, the Journal of Limb Lengthening and Reconstruction. It's easy. You will be able to read this article and hopefully it will make some sense. But firstly, we wanted to derive the rationale for performing these osteotomies. So what we did is we studied 118 segments in 59 patients who came to our outpatients over 6 months with complaints of medial compartment osteoarthritis. And what we found to our surprise that they fell neatly into 2 groups. One group had the mechanical axis deviation where the line, the Mikulicz line, passed at more than 10%. That is well within the knee joint but closer to the center at 10%. There were 57 of these segments. And another group of 61 where the mechanical axis was less than 10% of the joint width. So it just so happened coincidentally. And what we found that percentage mechanical axis deviation correlated with JLCA in the large deformities. So more than 10% is a smaller deformity, but the correlation is, this is the Pearson's R, is less. But for the larger deformities, which is denoted by the less than 10% sign, the Pearson's R is minus 0.66, which is a fairly strong correlation. The second thing that this talk is part of a prize presentation, so it's left brief, is we found a larger correlation with the condylar plateau angle. That's the difference in the angles of the 2 tibial plateaus. So therefore, the indication for performing a intra-articular osteotomy is a large varus deformity with a mechanical axis deviation at less than 10%, where the patient has a joint line convergence angle of more than 5%, or there is a mediolateral laxity in full extension. Here we are excluding the cruciate ligament injury type of patients and the youngsters who have got the classical noise type 1, type 2, type 3 vari, which we are not going to address. These are the middle-aged patients. So this is the clinical exam on the table, which shows the teeter or the mediolateral laxity. That's because the two condyles are not perfectly collinear. So we excluded those with frank lateral compartment arthritis, as in those having lateral joint line tenderness or OAR-SI osteophytes of grade 3 and more. So these are the patient demographics. Half of them had only an intra-articular, half had an intra and an extra-articular deformity. They were all very severe arthritis patients. Of course, all were advised an arthroplasty, but did not want one for various reasons. So let me show you the intra-articular correction, which is fixed with a plate. This is a lady with, you can see this is a pretty large varus deformity. HSS score of 35, mechanical axis is at minus 40%. This is a large JLCA. So hopefully the animation will run. And so this is an exaggerated view to show you, and this is how we perform the intra-articular osteotomy, elevate the medial condyle, and having fixed it, now the teeter or the mediolateral laxity reduces significantly. So in the surgical technique, very briefly, this is the vertical cut. After having done a patellar retinacular release, you see the picture-in-picture with the L-shaped osteotomy. We pre-drill the posterior cortex so that there's no comminution, and then the medial cortex is cut as well. So very carefully under the C-arm, there is an opening, minimal opening at the joint line, using two arthrodesis spreaders and a wire to prevent excessive opening at the level of the joint. We perform this and then we can fix this with an ordinary locking plate or a non-locking plate, whatever we are comfortable with. And here she is at the end of it. Her HSS has gone on to 82, and you can see that the mechanical axis is not completely corrected as one would want it to be. Okay, so now there are two aspects to this. This is definitely a little bit of an undercorrection, but the principle that Dr. Teramoto talks about is that when you elevate the tibial condyles, now both the condyles are in touch with the femoral condyles at the same time. So pressure is equal to force upon area. The area from a point contact in the medial condyle has increased to almost the entire joint width. So the area has increased, the force has reduced, and the cartilage is going to bear less of a brunt and is going to be able to regenerate. So that's the principle behind it, and that's why it works. But I presume, because we are new in our learning curve, it's only 3.5 years that we are doing this, is that one would rather want to perform even more. So we looked at our results, and we found that the joint line convergence angle from an average of 9.2 pre-op came down to 3.6, which is well within the reasonably normal limit. The condylar plateau angle, which is how we measure it between the two tibial condyles, reduced from a pre-op of 14.1 to an average of 4.5. The mechanical axis, with an average of pre-op minus 23.8, came up to an average of 36.1. Not perfect, but significantly better. And the mechanism of pain relief, as I tried to explain to you, is this excessive loading as denoted by the red color, and this very little loading here. Now, because of the uniform distribution and simultaneous contact, both the condyles of the femur and tibia are facing an equal and equitable and tolerable load. But we thought that we need to add on better correction so that we may have a good chance of a long-term pain relief, as we know that comes from good alignment. So this lady with an HSS score of 15, the mechanical axis at minus 44, and what's obviously an extra-articular deformity as well as the intra-articular. So hopefully the animation should explain the rationale. This is an exaggerated view of the toggle. This is the axis, so we perform the L-shaped osteotomy. We fix it with the two half pins and we correct this until we get a femorotibial angle of about 10 degrees, which is what Dr. Koshino had recommended, or a good Fujisawa point correction. Or in the diagrams, sequentially to show these steps. So the L-shaped osteotomy, here we are just medial to the patellar ligament, and we are going between the tibial spines, barely penetrating the the joint surface, and the L shape comes here, typically near the starting point of a medial opening wedge high tibial osteotomy, and about 2.5 to 3 centimeters below this is a slightly curved focal dome-like osteotomy with a generous fibular resection to permit this little bit of lateral translation, which is very important in Rule 2 until we get this good correction. So here she is with the Ilisarov fixator. Just the one ring fixes the intra-articular as well as the intervening fragment with 2 half pins. The intervening fragment may have thinner half pins like the pediatric ones. The shank is 6 mm, but the threaded part tapers from 4 to 3 rather than 5 to 4. And so that you're not fighting for real estate. And it's a classic configuration, and you can fine-tune this like any other X-fix or typically the Ilisarov to get a very good correction of hopefully the fix-it. I'm not sure if this movie will run, but they are surprisingly comfortable with the frame and this, and the intra-articular osteotomy tends to heal very pleasantly, surprisingly early. With an X-fix duration of only 2.5 months, this is the kind of correction she got, and this is her axis, and she's extremely happy at almost 3.5 years after the surgery. So the results of the combined correction we got were an improvement in the JLCA, an improvement in the condylar plateau angle, which is much more, but not statistically significant from the intra-articular alone group, and the mechanical axis deviation most gratifyingly from a -23, which had gone up to a +38% correction in the intra-articular, has gone up to almost 60%. So the X-fix adds a level of precision to this. Of course, we have had our share of complications. We've had delayed deep infection in 3 patients for various reasons, which are explainable. But fortunately, the osteotomy healed up, and all I had to do is remove the plate. In the second group, we had a very bad grade 3 pin infection of all the things in the lower tibia, but I have to mention this is not magic, and it took a while to heal. But there was one unfortunate incident where the elderly gentleman was befuddled after surgery, and he's a little obese, and he fell down trying to go to the gents, and he had a comminuted tibial tuberosity avulsion fracture for which we had to open and fix, and also put in an X-fix to span the femur. So this has resulted in some knee stiffness as well. Here again, so I'll conclude that if we use only medial compartment, medial opening wedge high tibial osteotomy, it's possible that we may unload the medial compartment, but we may not be able to entirely, shift the loads. If we overcorrect it, in such instances, we may overcorrect the lateral compartment, and I have experienced this in a couple of occasions when I have removed the fixator a little too early and the patient went on to collapse and get more valgus. He developed pain within a year. So, and then I had to undo and correct it. So this can happen if you just try to overcorrect for this phenomenon. And what we do in the TCVO is we are trying to make use of our understanding of where the deformity comes from. So we want to tackle the deformity from where it arises. This is opposed to this is a little different from the view of Babis and Saragaglia, who first promoted the double osteotomy, in which we were told to perform a lower femoral osteotomy. What we actually found in our analysis of the 118 limbs on long leg films is that there was a very poor correlation with the MLDFA. That's very few of the patients had a deformity actually in the lower femur. So my request to you, or my hopefully take-home message, is let's look at each patient's x-rays individually, treat him as an individual, and if you find a high MLDFA, then he needs a lower femoral deformity correction. But if the lower femur is normal, and you have a high JLCA and a high condylar plateau angle along with an extra-articular tibial varus, then you need to add an intra-articular correction as well. You may be surprised. A lot of the times I find the varus in a patient with medial compartment arthritis is coming from a bored femur. So now I have started performing double osteotomies with nailing in the femur. So we correct the deformity where it arises from. That's going to doing justice to where the deformity comes from. And here is a small subset which I have shown you that the deformity can arise from the joint, and we could be better off in treating it exactly where it comes from. I thank you so very much for your attention.